Hello everyone. So I welcome you all on the part 4 which was left behind. In this part 4 rapid revision we will be discussing second and third trimester problems. In here I would like to tell you all the guys who are watching, please like, subscribe my videos, my channel. It will help me a lot in my teaching, and that is the only gesture I want from you. It means a lot to me. Okay, so let's start it. So today we will be discussing the most important topic among the second third trimester is the hypertension in pregnancy. Hypertension in pregnancy, we usually get one or two question on it, so please do focus. It's a very important topic. Gestational hypertension. What do you mean by gestational hypertension? The gestational hypertension means the BP is more than 140 by 90 after 20 weeks, and first time it is high. The high BP is after 20 weeks and it is more than 150 by 90, and it has happened for the first time in the life. Okay, and these BP recordings are found on two occasions, 4 hours apart at least. Okay, and this increase in BP resolves after 12 weeks of pregnancy. Okay, all the complicated problems they resolve after 12 weeks. For example, secondary PPH is also up to 12 weeks. If PPH is more than 24 hours and up till 12 weeks, then it is known as secondary PPH. Otherwise, it is, if it is in the first 24 hours, it is known as the primary PPH. Okay, and here I would like to tell you that this gestational hypertension which occurs due to the placental problem, this problem also gets solved by 12 weeks of delivery. Okay, chronic hypertension, if the patient has high BP before 20 weeks or before the pregnancy, then it is known as chronic hypertension. BP values are same, more than 140 by 90. What is preeclampsia or preeclampsia toxemia? It is its new name. If along with the gestational hypertension there is present proteinuria, then it is known as preeclampsia or preeclampsia toxemia. Okay, and the proteinuria is how much proteinuria should be there to diagnose a patient as preeclampsia? Answer to that is more than 300 mg per every 24 hours, or protein creatinine ratio is more than 0.3, or +1 or more on the protein dipstick. Okay, +1 or more on the protein dipstick. Clear? Everything is clear. If proteinuria is present along with the high BP, then it is preeclampsia toxemia. If BP is high before the pregnancy or before 20 weeks of pregnancy, then it is chronic hypertension. If BP is high after 20 weeks of pregnancy, it means that it is due to the placental problem, and that is why this is now gestational hypertension or PIH. Okay, okay, questions, you know that they do come on this definitions. Now, what is mild preeclampsia? Mild preeclampsia is if antihypertensive mild preeclampsia is if BP is less than 160 by 100, roll of but high than 140 by 90 and less than 160 by 100. Role of antihypertensive is plus minus, and delivery is done at 37 week. You must not be able to see that, but you know, all of you know, you never do this question wrong. Delivery is done at 37 week in the case of mild preeclampsia. If the patient is if the patient BP is high, more than 160 by 100, or patient is showing any end organ damage, then it is a case of severe preeclampsia, and then the antihypertensives are given, and max sulfate 2 is given to avoid eclampsia, that you all know. Here delivery is done at 34 weeks. Okay, sometimes if BP is uncontrolled, then we do the delivery early, but usually in the case of severe preeclampsia, if the BP is controlled, then we do the do the delivery at 34 weeks. Okay, now let's go to eclampsia. It's very important. Now this is the main topic which is expected in your exams. Please focus. What is eclampsia? If along with preeclampsia toxemia or preeclampsia convulsions occur, generalized tonic-clonic convulsions occur, then it is known as eclampsia. Okay, the drug of choice for prophylaxis and for the treatment of that convulsions is max sulfate. You all know that. Okay, the definitive treatment is of course delivery. The definitive treatment is of course delivery for eclampsia, for mild preeclampsia, for severe preeclampsia. All the eclampsias, the delivery, the definitive treatment is delivery, termination of pregnancy. Okay, for eclampsia, the drug of choice for prophylaxis and treatment is max sulfate. Pritchard regime is given. Pritchard regime is 4 gram IV and 10 gram IM loading dose, followed by 5 gram IM every 4 hourly. If the three factors they are normal, or if there is no sign of magnesium toxicity. If there is no sign of magnesium toxicity. Question is highly expected from this area which we are discussing. Please focus. Okay, the loading dose is 4 gram IV or 10 gram IM is the loading dose. IV भी देना है, IM भी देना है. 4 ग्राम IV देना है, 10 ग्राम IM देना है. फिर the maintenance dose is 5 gram IM every 4 hourly. Okay, and and it is given 24 hours after the delivery or 24 hours after the postpartum seizure. Okay, it is given 24 hours after the delivery or 24 hours after the postpartum seizure, whichever is later. Okay, either it is 24 hours after the delivery or it is 24 hours after the postpartum seizure, whichever is later. Okay, so you have to learn every point. 5 gram IM is the maintenance dose and it is given up to what? Okay, and 4 gram IV and 10 gram IM is the loading dose. So this magnesium has a very narrow therapeutic range, 4 to 7. If the values goes above, then magnesium toxicity occurs. That is why always before giving the maintenance dose, we will check these 3 parameters. What are those 3 parameters? Knee reflexes, respiratory rate and urine output. Okay, we will check these 3 parameters. The therapeutic range is 4 to 7 milliequivalent per liter. The knee reflexes, they goes at 8 to 12 milliequivalent per liter. If magnesium levels are 8 to 12 milliequivalent per liter, then the knee reflexes they goes, and the respiration is affected at 12 to 16 milliequivalent per liter. So respiratory rate goes less than 12. Okay, so it is easy. 4 to 7, 8 to 12, 12 to 16, it is just a table of 4. Okay, just you have to keep in your mind all this thing. Okay, The therapeutic range of magnesium is 4 to 7 milliequivalent per liter. The knee reflexes they goes at 8 to 12 milliequivalent per liter, showing the magnesium toxicity. The respiratory rate falls to less than 12 at 12 to 16 milliequivalent per liter. After this, there is cardiac arrest. Okay, as magnesium is excreted mainly by the kidney, so urine output should be more than 30 ml per hour. Okay, as magnesium is excreted mainly by the kidney, so urine output should be more than 30 ml per hour, because if magnesium will not be excreted, it will cause the magnesium toxicity. So if magnesium toxicity occurs, then the antidote is calcium gluconate. Okay, the preferred delivery in preeclampsia, eclampsia is vaginal delivery. Cesarean is only done for the obstetric indication. The help on help again question comes. Help H stand for hemolysis. Hemolysis is indicated by high LDH, bilirubin more than 1.3, decreased serum haptoglobin, or peripheral blood smear showing abnormal cell. Once again, I'm telling you, the hemolysis is shown by number 1, increase LDH, number 2, bilirubin more than 1.3, decrease serum haptoglobin, and peripheral blood smear showing abnormal cells. Increased liver enzymes is also EL stands for, in help H stands for hemolysis and EL stands for or increased liver enzyme. AST and ALT, they both are raised more than 70. Okay, and there is LP stands for low platelet count. The platelet count is low, less than 1 lakh. Okay, less than 1 lakh. Got it? So this is HELP. Questions on HELP are 2 coming. The treatment of HELP is, yes, the treatment of HELP is if the it is a severe HELP, platelet count are less than 5,000, then of course its treatment is cesarean. Okay. Okay, next is antihypertensive. If in the labetalol, drug of choices, antihypertensive which we can give to severe preeclampsia patient are labetalol. Labetalol is a drug of choice for all these questions. Okay, for PIH, for preeclampsia, for severe preeclampsia, for chronic hypertension, for uncontrolled hypertension, for hypertension crisis, for all these, the drug of choice is labetalol. Okay, now if question in the question you don't get labetalol as option, so second drug of choice is nifedipine. And the third drug of choice is alpha methyl dopa. Okay, do you understand? The labetalol is drug of choice for each and every condition. If in the options labetalol is not there, you are going to mark there nifedipine, and if nifedipine is not there, you are going to mark alpha methyl dopa. The drugs which are contraindicated are ACE inhibitors, angiotensin receptor blockers, that are captopril, losartan, all these, diuretics, and beta blockers. You can remember this ABD. Okay, A stand for ACE inhibitors, angiotensin receptor blockers, B stand for beta blockers, D stand for diuretics, C stands, so you can say contraindication. I think, but you all know all these things, so need not to remember. Okay, magnesium sulfate, please focus on these 3 lines, they are very important. Magnesium sulfate is not anti-epileptic. Okay, it is not an anti-epileptic drug. It has no effect on BP. Magnesium sulfate questions are coming again and again on this line, that magnesium sulfate is not has no effect on BP. It does not lowers BP. High chances are there that question will come on either on eclampsia or on the magnesium sulfate. Okay, so please read it nicely. It has a no effect. This magnesium sulfate has no effect on BP. This magnesium sulfate is a tocolytic, is a tocolytic, and when it is given in early pregnancy, it has a neuroprotective effect on the child brain. Okay, the other effects of magnesium sulfate are those same as that on the mother: respiratory depression, knee reflexes, anti convulsant rest, all same effects are there, but it is neuroprotective when it is given in the very early pregnancy. Okay, when it is given in the very early pregnancy, it is neuroprotective. Okay. Okay, now one slide more and our this will be completed. Okay, what are predictors of preeclampsia? These are some new things that we have to learn. One is giant rollover test. Whenever giant rollover patient is made to roll over, the patient's BP decreases due to supine in vena cava syndrome. You know what, when supine vena cava syndrome, when patient lies down, vena cava gets suppressed, and that is why the BP falls. But if a patient has preeclampsia tendency, then the BP will get high. This is known as giant rollover test. Angiotensin sensitivity test, if we go for it, then again the BP rises in a patient of preeclampsia. What is uterine artery Doppler? Uterine artery Doppler is, this is a test which we do these days. And what is it basically? In usually there is a diastolic notching and it goes after 24 weeks. If the patient has preeclampsia tendencies, then it persists after 24 weeks. Okay, the diastolic notching which comes in the uterine artery Doppler, it persists after 24 weeks. Please, this point is also very important. Chota sa point hai, please make it a note. The uterine artery Doppler is a predictor of preeclampsia that we all are following clinically, and the diastolic notching, it persists more than 24 weeks. What are the signs of impending eclampsia or imminent preeclampsia? When a patient has severe preeclampsia, then we ask this sign so that we come to know that eclampsia is going to happen and we can properly manage the patient. Okay, so what are those signs? First sign are related with cerebral cortex: headache, blurring of vision, dizziness, all these things. Okay, what are signs of impending or imminent preeclampsia? Headache, blurring of vision, all this. Other signs are related with GI, vomiting, epigastric pain, nausea, all this thing. Okay, other signs are related with the GI: vomiting, epigastric pain, nausea, all this thing. And then the another sign is decreased urine output. Okay, decrease urine output. So one sign are related with cerebral hypoxia, that is headache and blurring of vision. The other group of signs is related with GI: headache, nausea, vomiting, epigastric pain. The third is decreased urine output. Okay, now usually why BP in preeclampsia raises after 20 weeks if it is preeclampsia? Because in preeclampsia the extravillous trophoblast, how you are going to remember extravillous? See, villous trophoblast will form the villi. Okay, so in a normal female, the extravillous trophoblast, it goes and remove the spiral artery. What are spiral artery? The arteries which are feeding the placenta. Okay, so what happens? The fetus extravillous trophoblast, they go and they remove the spiral arteries tunica media. Okay, so if this does not happen, then preeclampsia occur, and this occurs at 16 to 18 weeks. Fetoplacental circulation or this removal of the tunica media occurs at 16 to 18 weeks. If this does not happen, then extravillous trophoblast if it does not remove the tunica media of the spiral arteries, then preeclampsia occurs due to the vasospasm in the placental arteries. Okay, will you remember this? Questions are coming. These are all are the important one liners. Okay, you are not going to forget any of these lines. Okay. Okay. Now here usually it is told to diagnose the HELP syndrome. Okay, so then they give you in the option they give you hepatic cholestasis, acute fatty liver of pregnancy, and acute viral hepatitis. So here I am you to tell you how you will differentiate between HELP, intrahepatic cholestasis, acute fatty liver of pregnancy, and acute viral hepatitis. Okay, most important thing is you are going to see the liver enzyme in HELP. Along with the raised liver enzyme, hemolysis will be there, low platelet count will be there. Here no other in all these diseases is usually in the last stages the platelet count is affected. Okay, okay, when the patient goes in DIC. So if the patient is not in DIC, it is written that patient is not in the patient is having hemolysis sign, and patient is having elevated liver enzymes and low platelet count, then it is the HELP. If it is written that only the patient have mild raised in the liver enzyme and pruritus is itching, keeps on patient keeps on itching its whole body, and there is mild increase in the liver enzyme in hundreds. Okay, maximum up to hundreds. Okay, then it is a intrahepatic cholestasis. If there is a moderate increase in the liver enzyme along with nausea and vomiting, then it is moderate means it is in thousands, 1000, 2000, few thousands. Then it is acute fatty liver of pregnancy. Acute fatty liver of pregnancy along with nausea, vomiting, there is a moderate increase in the liver enzyme, then it is acute fatty liver of pregnancy. Okay, if it is a acute viral hepatitis, then there is a severe rise in the liver enzyme, many thousands rise in there along with fever and jaundice. Okay, okay, now we are going to the chapter twins. Twins are of two type, you all know, monozygotic twins and dizygotic twins. Okay, dizygotic twins means they are two separate zygotes are formed, so now they will develop separately, and they will have their different chorions, they will have their different amnion, so they will be dichorionic, diamniotic. Their sex can be same or different. Okay, but their genetic structure is always different. Okay, okay, what about the monozygotic or monochorionic twins? Monozygotic or monochorionic thing, either they will be dichorionic or monochorionic or monoamniotic, depends at what time they are splitting, at what time the single zygote is splitting into two. That will tell that whether it is dichorionic, diamniotic, monochorionic, monodiamniotic, or what else. Okay, so in these twins only the fingerprints are different, rest the genetic structure, the blood group, the sex, everything is same. Okay, monozygotic twins are known as maternal twins, whereas the monozygotic twins are known as the maternal twin, whereas the dizygotic twins are known as fraternal twins. Okay, now this is a question on these are coming a lot, how the different there is a different type of monozygotic twins depending on their time of splitting. Usually they give the time of splitting and they ask you, here again there is a table of 4, but this table of 4 is starting from 0. If the splitting occurs from 0 to 4 days, then it will be dichorionic, diamniotic, because by from 0 to 4 days no sac and no placenta is formed, so the divided structure will form their own amniotic sac and own trophoblast, so they will not be sharing. Okay, because up till 4 days no trophoblast is formed and no amniotic sac is differentiated. So the divided structure, they both will form their own amniotic sac and own trophoblast, so they are not going to share. Monochorionic and diamniotic Monochorionic and diamniotic twins, they develop. Monochorionic means same placenta, diamniotic means two sacs. So these are the most common out of the monozygotic and dizygotic. Dizygotic are most common. Okay, and out of the monozygotic, all the twins, the monochorionic diamniotic is most common. Okay, and these are twin form if the splitting of the single zygote occurs at 4 to 8 days. As the trophoblast is differentiated, so it's shared by the twins, because by 4 to 8 days the trophoblast is formed or trophoblast has been differentiated. Now the splitting of the rest structure will occur. Trophoblast will not split now. Okay, the embryonic cell mass will split into two. The trophoblast, because it is already differentiated, so it will not split into two. Only the left embryonic cell mass will divide into two, so they will share the same. The resultant fetuses or the resultant embryo will share the same placenta, because trophoblast has been differentiated, and this is from 4 to 8 days. Okay, monochorionic monoamniotic twins are from 8 to 12 days, because by 8 to 12 days both amniotic sac and trophoblast both are differentiated. So now only embryonic disc will is left to divide. So now embryonic disc will divide, and only the fetuses will be different, but they will be having the same sac and same chorion or placenta. Okay, conjoined twins are formed if the splitting takes place after 12 days. Okay, now let us see how we will differentiate dichorionic. How we'll come to know that whether the twins are dichorionic diamniotic or monochorionic diamniotic. You know that in dichorionic diamniotic there will be two placenta, and monochorionic diamniotic there will be one placenta. But these two placentas of dichorionic and diamniotic, they are kept near, fused. So it is not possible to differentiate it on ultrasound, because usually the dichorionic placentas, they are lying nearby, and they are kept nearby and fused. And whereas in monochorionic there is only one placenta and two sacs. So if there are two sacs, we have to see that whether it is dichorionic or monochorionic, right? It can be any, right? If there are two sac, then it can be dichorionic or monochorionic. So to differentiate that chorionicity, whether it is dichorionic or monochorionic, that chorionicity is seen at 11 to 13 weeks. Okay, twin peak sign or lambda sign is positive in dichorionic diamniotic, because if there are two in dichorionic, two placenta are present. If two placenta are present, they will go in between the two sacs, and that forms a twin peak or lambda sign, whereas these both are absent in the monochorionic monoamniotic twin. The intertwin membrane will consist of two chorions and two amnion. In the case of dichorionic diamniotic, the intertwin membrane will consist of chorion and amnion. But whereas in the monochorionic diamniotic, only amnion will be in the, so there is increased thickness as of the increased thickness. It is thickened intertwin membrane, whereas in monochorionic diamniotic, because there is one placenta, only amniotic sacs are different, so it will consist of intertwin membrane will consist of only amniotic membrane. The complication TTA traps are much common in monochorionic, because when they share the same placenta, then they have problem like twin to twin transfusion syndrome and traps. And now how to differentiate dichorionic diamniotic and monochorionic diamniotic on the basis of by seeing the placenta in between the two cords. If there are three membranes, okay, many membranes are present, then it is dichorionic diamniotic. If between the two cords only a thin membrane is present, then it is something is present, because you know that in monochorionic diamniotic only amniotic sacs are there, placenta is one. ठीक है, so if only thin membrane is present, then it is monochorionic diamniotic. Okay, now something about the monochorionic monoamniotic twins. The monochorionic monoamniotic twins, the most common complication which is seen is cord entanglement. Therefore, elective cesarean is done at 32 to 34 weeks. And how we will differentiate it on the basis of placenta, by seeing the placenta between the two cords. If no membrane is present, then it is monochorionic monoamniotic. Between the, you have to see, when you are seeing the placenta, you have to see the area between the two cords. If only one membrane is present, then it is monochorionic monoamniotic. If if one membrane is present, then it is monochorionic diamniotic. If many membranes are present, then dichorionic diamniotic. If nothing is present, then monochorionic monoamniotic. Delivery in the case of twins, vaginal delivery is done only and only first twin is vertex. Okay, and cesarean is done if first twin is breech or transverse. Second twin can be given if second twin malpresentation or transverse lies there, then you all know that internal podalic version का ऑप्स में एक इंडिकेशन है second twin. Okay. Okay, this was about the twins. Little more about the twin to twin transfusion syndrome. In twin to twin transfusion syndrome, one is donor and the another is recipient. One is donor and the another is recipient. In the donor, because donor is giving its blood to the recipient, so donor has anemia, urine output decreased and growth is decreased. Due to decreased urine output, there is decreased oligohydramnios, decreased AFI. The recipient, on the another hand, is polycythemic, increased urine output, polyhydramnios, and increased growth. Okay, what is differentiation between superfecundation and superfectation? This question is in trend. Superfecundation का मतलब है एक ही मंथ में दो जाइगोट्स बनना, एक ही मेंस्ट्रुअल साइकिल में दो जाइगोट बनना, यही ह्यूमन बींग्स में होता है. ठीक है, सुपरफिटेशन एनिमल्स में होती है, उसमें अलग अलग मेंस्ट्रुअल साइकिल में, यानी इस मेंस्ट्रुअल साइकिल में एक जाइगोट बना, अगली मेंस्ट्रुअल साइकिल में अगला जाइगोट बना, तो उसमें जो बच्चे पैदा होते हैं वो अलग अलग टाइम के होते हैं. कोई 8 महीने का होता है, कोई 9 महीने का होता है, अगर उनका पीरियड ऑफ गेस्टेशन 9 महीने है तो डिलीवरी के टाइम पे पीरियड ऑफ गेस्टेशन अलग अलग होता है हर बच्चे का, क्योंकि ह्यूमन बींग्स में पीरियड ऑफ गेस्टेशन सेम होता है, तो ह्यूमन बींग्स में सुपरफिकंडेशन होती है, फिकंडेशन. ओके, वैनिशिंग ट्विन और फीटल पेप्रीशियस का क्या मतलब होता है? कई बार एक ट्विन एक्सपायर कर जाता है. अगर डिलीवरी के टाइम पे वो ट्विन अगर प्रेगनेंसी के टाइम पे वो ट्विन फर्स्ट ट्राइमेस्टर में एक्सपायर किया है, तो यूजली वैनिशिंग ट्विन होता है, क्योंकि जब डिलीवरी होती है उसका कोई नामो निशान नहीं होता. फीटल पेप्रीशियस का मतलब क्या? यूजली ये सेकेंड ट्राइमेस्टर में जब ट्विन एक्सपायर होता है तो फीटल पेप्रीशियस होता है. इसको पेप्रीशियस क्यों बोलते हैं? क्योंकि जब डिलीवरी होती है तो एक पेपर जैसा एक फीटस दिखता है, पतला सा पेपर जैसा. वैनिशिंग ट्विन मतलब नामो निशान नहीं दिखेगा, और ये फर्स्ट ट्राइमेस्टर में जब फीटस डिमाइस होता है तब होता है. फीटल पेप्रीशियस का मतलब होता है पेपर जैसा ट्विन, और ये यूजली सेकेंड ट्राइमेस्टर वाले फीटस में होता है. जीपीएल जिन जिन लोगों को नहीं आता था मैं बता दूंगी. जी का मतलब होता है ग्रेविडा, यानी वो लेडी कितनी बार प्रेग्नेंट हुई है. मैं भी इस क्वेश्चन में बहुत कंफ्यूज होती थी, तो उसको ऐसे ले लो, कितनी बार यूपीटी पॉजिटिव आया है. तो अब आप समझ गए, अगर ट्विन्स भी है यूपीटी तो एक ही बार पॉजिटिव आया है. तो अगर अबॉर्शन हुआ है तो भी यूपीटी पॉजिटिव आया, तो अबॉर्शन को भी ग्रेविडा में लेना है. जी का मतलब है ग्रेविडा, और या फिर यूपीटी कितनी बार पॉजिटिव आया है. पी का मतलब है पैरिटी, कितनी बार उसकी प्रेगनेंसी मोर देन 28 वीक्स पे गया है उसका यूट्रस, उसका यूट्रस कितनी बार मोर देन 28 वीक्स पे गया है। अगर मान लो इस प्रेगनेंसी में वो लेडी आती है एट 32 वीक्स, तो उसकी पैरिटी ये नहीं मानेंगे, ठीक है। पैरिटी का मतलब कितनी बार उसकी डिलीवरी हुई है 28 वीक्स के बाद। अगर ट्विंस हैं तो पैरिटी एक ही है, क्योंकि डिलीवरी एक ही बार होती है ट्विंस की, राइट। तो कितनी बार डिलीवरी हुई है या कितनी बार वो डिलीवरी रूम में एंटर की है और मोर देन 28 वीक्स के फीटस की डिलीवरी हुई है। तो इसको मैं तो यूँ ही लेती हूँ, कितनी बार वो डिलीवरी रूम में एंटर हुई और मोर देन 28 वीक्स के फीटस निकाले उसने अपनी बॉडी से, ठीक है। डिलीवरी रूम में एंट्री, अगर ट्विंस है तो डिलीवरी रूम में एंट्री तो एक ही हुई है, ठीक है। दैट्स इट। एल का मतलब है कितने उसने लाइव बच्चों को जन्म दिया। कैलोरी रिक्वायरमेंट इन प्रेगनेंसी, इसके लिए मैं बता रही हूँ, माइल्ड जो वर्कर होते हैं, मॉडरेट एट और सीवियर, ठीक है। माइल्ड जो काम करते हैं, सीडेंट्री लाइफस्टाइल है, उनकी लगभग 1000 किलो कैलोरी है। मॉडरेट वालों की 2000 है और सीवियर वालों की 3000 है। ये इसलिए इसलिए लिखा है, ये प्रेग्नेंट लेडी की नहीं है, ये नॉर्मल लेडी की है। ये इसलिए लिखा है क्योंकि सब क्लिनिशियंस ऐसे ही याद करते हैं, ठीक है। माइल्ड जो सीडेंट्री जिसका लाइफस्टाइल, उसके 1000 किलो कैलोरी पर डे रिक्वायरमेंट है फीमेल की। जिसका मॉडरेट लाइफस्टाइल है, टीचर्स, डॉक्टर्स, उनकी 2000 किलो कैलोरी है। जो लेबर वर्कर्स हैं, लेबर क्लास है, उनकी 3000 किलो कैलोरीज पर डे है। अगर इसको प्रेगनेंसी में काउंट करना है तो +300 कर देंगे। मिनिमल विजिट्स बाय हु, WHO की मिनिमल विजिट्स बेटा 8 है। इस क्वेश्चन को प्लीज़ अपने कंसेप्ट्स को क्लियर कर लो। बहुत ज़्यादा अगर आपको आगे जाना है तो अगर वो फोकस्ड पूछते हैं, फोकस्ड ANC बाय WHO, तो 4 बोलना है, अदरवाइज आपने 8 ही बोलना है। ओके, that all about today class. See you soon tomorrow. Oh, once again I'm telling you, all the guys who are watching, please like and subscribe my channel. Please share it to all the one in need. Okay, it will help me a lot in my teaching journey. Thanks for your thanks for your cooperation. See you soon tomorrow.